So now you can have blood flow that can trickle across here and go to the part. That's a PFO.
But not enough.
Right. It's a patent foramen ovale. In other words, it's all together there, but it's not closed off. An atrial septal defect is this, where either this didn't meet or this didn't meet, so now you got a big hole there. It's definitely going to shunt when you've got a hole. So the difference between a PFO is a potential space versus an actual space.
The PFO can still open a little bit, but not much. And not a lot of blood will get shunted.
No, it's just going to be a little bit at a time.
Okay.
And it's only probably going to be when you cough or sneeze or have bowel movements or lift heavy weights or some bowel salve, those kind of things.
When the cardiologist yells at you, wet your pants, that's when
When? Yeah.
when the cardiologist is yelling at you and you peed your pants.
So in the fetus, we have right to left shunts, because in the fetus, this is all filled with fluid, right? The lungs are filled with fluid here, because the baby's breathing in amniotic fluid, so there's fluid in the lungs. You get really, really high resistance, and so in the fetus, the shunt is going to be from right to left. That's what we want, because our only pumping chamber is the left ventricle. Okay, so in fetal development, we have a right to left shunt. When the baby takes its first breath, the fluid disappears, the pressure goes down, and now it closes off the PFO. Okay, so in fetal development, we have right to left shunts. So with a moderate to severe atrial septal defect, which we have in utero, but not after the baby's born, the ratio is not fixed. So let's say they still have a hole there. So eventually, the pulmonary vascular resistance is going to be greater than the systemic vascular resistance. So the shunt switches, just exactly what I explained.
Yeah.
Okay. So when the shunt switches again, so when they're born, that's right to left. They take their first breath, now it's left to right. And then over time, as the lungs get more obliterated, then the pressure goes up in the right side, and then it switches back to right to left. So they have a less than normal QP. They have less than normal pulmonary flow and cyanosis, and then the pulmonary vascular pathology is irreversible. Once the capillaries are obliterated in the lungs, then, like I said, it's irreversible. So we want to keep this from happening. Okay, that's our goal. So if we see an ASD on an echo, we're thinking this got to be fixed. Okay, and they do. So with an atrial septal, except in Haiti, yeah, then they're just like, they say go home and take your chances with the games and the violence. ASD is the least of your worries, at least now. So an atrial septal defect, we're going to utilize all of our views. We're going to look at our parasternal sword axis view at the left atrium. We're going to look at our four-chamber view to make sure there's no hole going across there. We're going to look at our subcostal view to make sure there's no hole over there. That's why in our protocol we have to look at the interatrial septum and color them. Not likely anybody in here has a PFO. I guess 1 in 4, but nobody in here has a PFO. Nobody in here has an ASD. But every time you look at your subcostal view, you're going to make sure that there is no hole there. Hopefully our protocol that I gave you on second week, maybe, hopefully that protocol is now explaining all the things that we can see in an echocardiogram. We measure the LVOT so we can make sure they don't have aortic stenosis. We put pulse wave in the outflow tract, pulmonary outflow tract, so we can, the left ventricular outflow tract to make sure there's no, atrial septal hypertrophy with an outflow tract obstruction. We put continuous wave through there to make sure there's no aortic stenosis. So our protocol basically covers, if you do the protocol, then you're going to cover just about everything that could potentially happen in the heart. And then it gives you the tools to deviate from the protocol and go check this out and then come back to the protocol and keep on going. So we're going to utilize and compare all possible views. We're going to look for an echo-free space along the interatrial septum. We're going to see turbulent color flow Doppler through the ASD. We're going to document the atrial septal defect location. Is it a primum? Is it a secundum? Is it a sinus venosus? We're going to document what direction the blood flow is going. We're going to measure the size. If you're doing your 2D echo and you see in your subcostal view, or let's say you see in your four-chamber view, let's do the subcostal. So you got subcostal and you see your atrial septum like this. You're going to put a caliper here and here and measure this distance here. So you can report that it's a 1 centimeter hole, or it's a half a centimeter, or it's a 2 centimeter hole. So you're going to measure this hole here so that you can document that. We're going to measure the velocities going through there and the pressure gradients. Evaluate any associated findings. If you've got an atrial septal defect, is the right ventricle big? Is the right atrium big? What other value can tell us if there's increased pressure in the right ventricle? We've got tricuspid regurgitation. We're going to measure the velocity. We're going to measure the peak gradient. We're going to look at the IVC. We're going to have a sniff, and we're going to measure what the right ventricular systolic pressures are. We don't want to wait until the right ventricular systolic pressure goes from 25 to 125. We want to measure it and say, okay, the right ventricular systolic pressure is 45. We've got room to work with. We can deal with this. We can't deal with this. So we want to measure their tricuspid regurgitation velocity and figure what their pulmonary artery pressures is. How stiff are these lungs? So that's what the tricuspid regurgitation, the velocity and the gradient tells us, and then looking at the IVC. So we can get this number right here and say, okay, we have mild pulmonary resistance or mild elevation in pulmonary artery pressure. Let's reverse that. Let's switch this. Let's make this better. So that's why we do our tricuspid regurgitation. So all of the things on the protocol we do for a reason, not just because it's an exercise in pushing the buttons and memorizing a protocol. Got it? It's there for a reason. So we can acquire our right ventricular outflow tract here in our outflow view. We're going to acquire this right ventricular outflow tract. So this is our RVOT. We're going to acquire our LVOT and our parasternal long, our LVOT like we do on every echo. So now we've got our LVOT, and then we're going to get our cross-sectional area. So 2 times the LVOT times 0.785 will give us the cross-sectional area, or 1/2 of the radius squared. Those 2 formulas, anybody know what I'm talking about?
Yeah. We all did the acid today. We all did the acid today.
Yeah. So when we did our aortic stenosis and we used the continuity equation, we measured the cross-sectional area, and we had 2 choices to get that. You could either divide the diameter by 2, take that times 3.14, or you could do 2 times the LVOT times 0.785. Anybody remember any of that?
Yes.
Okay.
So I have memorized? No. But I remember.
Well, you don't. The machine does that for you. So you're going to do the cross-sectional area, and then you're going to take the VTI. In order to get the VTI, You got to trace around. So if you've got it in your pulmonary outflow, you're just going to trace around this and you're tracing around it anyway, right? Every time you put pulse weight here, you're tracing around it. Every time you put continuous weight through here, you're tracing around it. So you get the VTI. So the outflow tract, so cross-sectional area times VTI equals the QP or the QS. So here it says 10.785 times the RVOT squared, and all of this formula gives you the stroke volume here versus the stroke volume here. Okay. Or as in this formula, that's the stroke volume in the right ventricular outflow tract versus divided by the stroke volume in the left ventricular outflow tract. Gives you the QPQS, or how much flow, because it should be 1-to-1. All right, we've got one down. Now we're going to talk about ventricular septal defects. So your familiarity with ventricular septal defects is when we look at the when we do our parasternal long like this, and we've got the aorta coming off like this, and right here is a little membrane, okay? And this can have blood flow. So this is a ventricular septal defect. This is blood going across the ventricular wall, not the septal wall. So when you guys put color flow here, what are you missing? You're missing the point, right? So your color flow has to cover this area here so that you make sure there's no flow. So it's right where the aorta stops and where the muscular septum starts. It's a little teeny membrane right there. Don't quote me on this because the slides are going to prove me wrong. I think that's about 75% of all ventricular septal defects. So that's why we're putting color flow on here, to make sure that this high number of VSDs is not the case. So ventricular septal defect, it's the failure of the interventricular septum to close properly during fetal development. So blood shunts across the interventricular septum between the ventricles. Okay, so now instead of shunting through the atrial septum, we're shunting through the ventricular septum. Because the left heart's over here and the right heart's over here, and pretend like they're not even connected. Okay? The left heart has to pump to the body, the right heart has to pump to the lungs. And there should be no communication between here or here. None. Zero. Nada. None. No communication between these two. So if we have an atrial septal defect, we've got a communication. If we've got a ventricular septal defect, we've got a communication. Where is this communication? That's the question. So it's the failure of the interventricular septum to close. So you got a hole in the ventricular septum. So we can have what's called an endocardial cushion defect, also known as an AV canal defect. So it shunts between the ventricle and the atrium. So endocardial cushion defect is when, and I think it talks about this specifically. I should have looked at these slides closer, but I thought I was an expert on this. So we look at our heart. We've got right ventricle, left ventricle, right atrium, mitral valve, and tricuspid valve, and right atrium. So all of this, the atrium come together, the atrial septum comes together here, the ventricular septum comes together here, this mitral valve leaflet comes there, I'm sorry, tricuspid, this mitral valve leaflet combines there. So this is a very busy area right here. There's a lot of stuff that has to come together here in order to make the heart work. With an endocardial cushion defect in fetal development, none of this occurs. Okay, so you got a heart that looks like this. You got one valve here that hopefully goes all the way across. You got another valve here, and you've got a hole here, you've got a hole here. So all of this in the middle of the heart, this is called the crux of the heart, just disappeared, didn't form. So now you've got blood flow, not only going, so you have a primum, atrial septal primum defect. So blood's going to shunt from left to right here, blood's going to shunt from left to right here, because you have no closure points here. And these two valves come together like this. It's like one big valve trying to close off blood flow going across here. But you've got a hole here and you've got a hole here. So that's it, endocardial cushion defect. That's one form of the ventricular septal defect. And I think we're going to talk specifically about endocardial cushion defects, or
So is that in the book?
Yeah, the Cushing is this one, and it says it's known as atrioventricular
Oh,
defect.
sorry.
Yeah, it's like-
Yeah.
we had Jennifer from Children's come in here to give us a talk several years ago. And she used AV canal defect exclusively. She never said endocardial cushion defect. So I guess endocardial cushion defect has gone out of favor for at least at Children's here for AV canal defect, atrioventricular canal defect. But that's just one form of VSDs. So let's move on. The size of the VSD can obviously vary, and many VSDs require surgical repair. You know, if you've got communication between the left ventricle and the right ventricle, you got the same setup that you have for an atrial septal defect. So you want to go in there and you can repair those, either surgically or by taking this wire and going into the heart and putting this wire across here and deploying a wall here and pulling it back and deploying a wall here. So you can close up a VSD with a closure device, just like you can the atrial septum. So instead of surgery, you can do it with a catheter. So again, with a ventricular septal defect, you can have a volume overload. You can have more blood flow going to the right heart than the left heart. And so you get Eisenmenger syndrome if it's going from left to right. If it's large, you can have it kind of sloshing back and forth between left heart and right heart, and now both chambers are going to get enlarged. You can, because of this shunt from left to right, you're going to get an increase in pulmonary vascular resistance, you're going to get pulmonary hypertension, and an Eisenmenger syndrome where it switches to right to left instead of left to right, and it leads to all kinds of lung problems.
So, but the thing it says here on the slide, that it's common for small to medium spontaneously close with growth. So like premature babies, they see it sometimes and then just wait for a certain period of time to see if it takes care of itself before they do surgery.
Yeah, sometimes a VSD will close on its own. So if the baby's born with a small VSD, they'll just watch it. Because typically the ventricular septum will grow and seal off
Like
that.
a year old, they watch it for a year or something.
Or, you know, watch it for as long as it takes to hopefully that it'll close off.
So there's a time frame. When would that trigger surgery, I guess is the question.
Depending on the baby's health, depending on the decision of the parents, do we want to go in and you know, if the baby's out playing and cooing and eating and thriving, and they'll probably just watch it, keep watching it, and you know, keep fingers crossed. And then eventually, if the baby starts not keeping up with the other kids, then they gotta close this. So there's a whole range of factors that play into that. You know, the surgeon has to, you know, is going to, you know, Europe and needs to pay for a trip to Europe. You know, he's gonna want to do
Or
surgery.
Paris, so yeah.
Yeah, so he's gonna want to pay for that trip, so he's gonna do surgery. I'm so sick of it,
Realistic.
among other things. So VSDs can be of several types. I said 75%, 80% are this perimembranous or a membranous VSD, that little tissue between where the ventricle comes up here. You can see it kind of shows the muscular part, and then there's a little membrane right there. So that's going to be our perimembranous VSD. 80% mortared by the tricuspid valve, the aortic valve, and the muscle. So tricuspid valve, that is, I guess, the tricuspid valve is coming in here. Tricuspid valve, the aorta, the mitral valve, and the muscle there. It's usually really, really high on the interventricular septum. It's thinner, it's a more flexible portion, closer to the valves, great vessels, and it's frequently aneurysmal. So when you do your 5-chamber view, so you've got your 4-chamber like this, and you've got your septum, and you do your 5-chamber view like this. Sometimes this little membrane right here is like this. So when you do your 5-chamber view, you can sometimes see this little membrane, and it's, remember when we talked about an interatrial septal aneurysm where it's kind of blowing in the wind like a sail in the wind, or a sheet out on the clothesline in the summertime? If I remember those days. It's really screwed up our baseball games in the backyard when Mom would put all of her clothes out on the clothesline. But anyway, so you can see it kind of flopping around here, and so you get, there can be a little hole right here where it's flopping around. So then we can have a trabecular. Trabecular just means the muscular part of the ventricular septum. So in this case, it's showing that you just got a big hole in the muscular portion, and that's about 5 to 20% of VSDs. So it's between the right ventricle and the left ventricle. It's usually lower in the muscular portion, closer to the apex, and there can be multiple defects. You can have what they call a cheesecloth effect, where you got all kinds of little holes in here. And hopefully those are the ones that are going to close up the biggest one. So a membranous, or AKA perimembranous VSD, or a muscular VSD, the two most common. And then you can have an outlet VSD, which is about 3 to 5% is between the left ventricular and right ventricular outflow tract. And one of these is called a supracrystal inlet VSD. That's number 4. 3 outlet. Look in your book and see which one's called a supracrystal VSD. Which one? The outlet VSD, that's a supracrystal VSD. So when you do your parasternal short axis view like this, you've got your pulmonary artery here, and you've got your tricuspid here. So one of the reasons that we put color flow on the aorta here and kind of make our color big is because if you see color flow going across here at about 10 o'clock, that's either going to be a membranous VSD, or it's going to be an inlet VSD. Or if you have your parasternal long axis view, you've got your aorta coming off, and you see color flow going across here, that's either going to be a perimembranous or it's going to be an inlet VSD. To be honest, I don't know the difference between an inlet and a perimembranous VSD. I just call all of these perimembranous because I can't spatially understand the difference. They look, on echocardiogram, they look identical. But if you see blood flow going across here like this into the outflow tract, that's an outflow VSD. Okay, so the difference between perimembranous and inlet by echo, we can't really tell the difference. You're going to see flow going across here on both. You're going to see flow going across here on both at about 10 o'clock. And this is about 1 o'clock. Okay, so this is an outlet VSD going into the outflow tract. Okay, you can remember it that way. It's also called a supercristal. Supercristal VSD. This is what it's typically called instead of an outlet VSD because it's easier to remember. So if you see blood flow going here, it's an outlet or supercristal. You see blood flow going this way on your short axis, it's either going to be a perimembranous or an inlet VSD. I call all of these perimembranous VSDs. And nobody argues with me. Probably in order to determine if it's an inlet or if it's perimembranous would be either to do a 3D echo or to do, heart surgery, to go in and see exactly where it is. Because they both kind of end up in the same place. Okay, so an outlet VSD versus an inlet VSD. The outlet is going to shunt blood over into the pulmonary artery. The inlet is going to shunt it over to the right ventricle. Okay. Inlet VSDs are typically associated with endocardial cushion defect. That makes sense because of all that stuff in the middle has to come together. If it doesn't, you're going to have an inlet VSD. And then you get the malalignment VSDs where you can have a situation where, and we're going to talk about this when we talk about another. So let's look at the heart anatomically. So we've got ventricle here, and our aorta. So let's say this is the left heart, left ventricle, right ventricle, and our aorta should come off of the left ventricle like this, right? And our pulmonary artery should come off the right ventricle. Well, there's some conditions in which the aorta doesn't go right directly to the left ventricle. The aorta does this. So it overrides the septum here. So you got blood flow from the right going into the aorta and blood flow going from the left side into the aorta. It's overriding the septum here. So you've got a VSD here, right, from left to right, because you've got malalignment of the aorta. The aorta should be shifted over here and connected exclusively to the left ventricle. But if it's shifted this way and overriding both chambers, I mean, just by definition, you've got a big hole right here. So you've got a malalignment where the aorta is malaligned. It's not where it's supposed to be, overriding both chambers. And we'll talk about that when we talk about another. List 2 examples of malalignment VSDs. I'm going to talk about one of them for sure. So, okay, so VSD, utilize and compare all views. We're going to really closely look at the membranous septum in our parasternal long axis view. We're going to look for any echo-free spaces along the interventricular septum. We're going to look for any areas of turbulent color flow Doppler along the ventricular septum. We're going to document the VSD, and then we're going to evaluate any chamber enlargement or anything like that. With the ventricular septal defect, we want to put continuous wave Doppler through it and get the gradient through there. Because if you've got a ventricular septal defect say here, and you've got a really, really little hole, little tiny hole, and you put continuous wave Doppler through here, would you expect the velocity to be high or low? It's a really small hole, high. So the velocity is going to be higher. So the pressure gradient is going to be higher through here. What if you have a really big hole? Would you expect the pressure to be higher or lower? Pressure is going to be low. So let's say we're doing our parasternal long axis view, and we see a blood flow going across here, we want to be parallel with that. So we're going to put continuous wave Doppler through here, and if we get a pressure, let's say we get a velocity of 5. 5 times 5 is 25, 4 times 5 is 100. So we got a pressure of 100 through here. What if we get a velocity of 3? So 3 times 3 is 9, 4 times 9 is 36, so our pressure gradient is 36. The higher the pressure, the smaller the hole. So we can determine how big the hole is by putting continuous wave Doppler through there and getting the velocity and getting the pressure gradient here. In other words, if the hole is really small, you're going to have a higher pressure trying to push through this hole, so the higher the pressure gradient. So in this situation, you want a high pressure gradient. You want a pressure gradient of like 100. Okay. By the way, you can calculate the pulmonary pressures with this too. Let's say your blood pressures, you take the blood pressure in your arm and it's 125, and we take this gradient across here. So it's just like tricuspid regurgitation. Now we know the difference with this pressure gradient. So let's say we got 100. So the difference between these two is 100, and this is 125. So we know that this right ventricular pressure is 25. So not only can we use tricuspid regurgitation to calculate pulmonary artery pressures, we can use a VSD. They have a VSD. We can calculate what the pressure is in the right heart or the right ventricular systolic pressure. Anybody follow me?
Sort of, but yes.
So it's the same thing if we've got tricuspid regurgitation here. We're measuring the difference. We're measuring the pressure gradient. Remember, gradient equals difference. So if we know the difference here, and we know what this is because we looked at the IVC and we had them snip, so we add 3 here. So if we know this is 3 and we know the difference, let's say the difference is 25. So then we can calculate, we know the difference and we know this, then we can calculate the right ventricular systolic pressure. Same thing here. We know the difference and we know this because of the blood pressure, then we can calculate this. We've got 2 of the 3 variables that we need. So whenever they have a VSD, what I always did was, so I had this VSD here, and I put my continuous wave through here. So when I had my Doppler here, and I got a velocity of 1, 2, 3, 4, 5, so it was like this, I would measure it here and get, it would come up on my screen here as 100. Then I would type in arm pressure, arm systolic pressure 120, so the doctor knew to subtract, or I would even sometimes annotate this on the screen. Right ventricular systolic pressure equals 20, because they could see that this was 100 and the arm pressure was 120, so then they could just do the math and calculate, or I would do a form that the right ventricular systolic pressure is 20. And hopefully, if you have tricuspid regurgitation at the same time, you're going to get pretty close. You might have, 22 here, and you would have 20 here. So now you've got 2 numbers telling you what the what the pulmonary artery pressure is. So if you see a tech, if the patient has DSD and you see a tech put continuous wave through there and just measure what the peak gradient is, you can tell how big the hole is, but how high the velocity is, or how much pressure there is there. But also you can take it one step further and measure the pulmonary artery pressures. So patent ductus arteriosus, remember in fetal circulation, so the fetus, right atrium, right ventricle, left atrium, left ventricle, blood flow going out of the right ventricle can't go to the lungs. So this blood flow that comes into the right atrium in the baby can't go to the ventricles. Okay, if it does, it can't go to the lungs. So that's why we have a shunt here in the baby, so that the blood can go over here and go to the left ventricle and get pumped to the baby's body, back to the umbilical cord, all that stuff. So we got to have a shunt here. But what if some blood does dribble back into the right ventricle and it goes out the pulmonary artery? Well, it can't go to the lungs, so we've got our aorta here, like this. So we have a communication between here. So that any blood flow that goes out the pulmonary artery now gets shunted into the aorta. So we have two mechanisms to keep blood from going to the lungs. The atrial septal communication here with the PFO, and then this ductus arteriosus that takes any oxygenated blood from the pulmonary artery over to the aorta. So it completely bypasses the lungs. So what if this doesn't close off? Then we have a shunt going from the aorta left to right. This is because after the baby takes its first breath, now this is 125, and over here is going to be 25. So the blood flow is going to go from the aorta into the pulmonary artery. It's going to shunt that way, left to right, high pressure to low pressure. So that's what a patent ductus arteriosus is when this doesn't close off or doesn't scar down, it turns into a ligament normally. If it stays open, then you've got blood flow going from the aorta or left heart back to the pulmonary artery. So you got a left to right shunt with a patent ductus arteriosus. So in the uterus, the pulmonary vascular resistance is so high that is higher than the systemic vascular resistance. So we have two shunts. The ductus arteriosus shunts right to left in the baby. Okay, so it goes from the pulmonary artery through the ductus arteriosus and into the aorta. Okay, so it shunts blood away from the lungs. At birth, the ductus arteriosus closes within about 15 hours. It closes off, it just shrinks down, and then eventually forms a ligament. So it's completely sealed off in a ligament within 2 to 3 weeks. If it fails to close, then we have a patent ductus arteriosus, and we have a murmur, and the blood flow shunts from the aorta back into the pulmonary artery. So we have a left to right shunt. So if we have at birth systemic vascular resistance is greater than pulmonary vascular resistance, so the PDA reverses direction and travels left to right, what I just said up there. Sometimes the PDA remains bidirectional. In other words, it goes back and forth. So this flow reversal, this left to right shunt, again, just like all the other shunts, puts a burden on the heart and the lungs. So where you're going to see that is when you do your peristernal short axis view. So you've got your aorta here, you've got your pulmonary artery here, with your pulmonic valve here, and then this comes down here and you get your britches right here, okay? So you're gonna see the shunt, the aorta comes sort of like behind here, like this. So it's gonna shunt back through that ductus arteriosus, and you're gonna see red blood going this direction, okay? This is not pulmonic regurgitation. Pulmonic regurgitation is going to be up here, where you're going to see red flow coming from this area where it bifurcates right here. It's another good reason, once you guys get more experience with getting the views that we're trying to get you to see, then you can focus on this pulmonary artery and say, okay, if I point up just a little bit, I can see these britches just to make sure that there's no blood clot in here, that the right and left are about equal size, and that there's no backflow through this ductus arteriosus. So this is where you're going to see it. You might also see it in your arch view. This is the pulmonary artery right here. So sometimes in your arch view, you can see the blood flow going from the aorta into the pulmonary artery here.
We just decrease depth to see it, or angle down, or
Here, angle up.
angle up.
Sort of angle more anterior a little bit. Okay. And it's pretty rare. I've only seen in adults, I've only seen it, 1 or 2 times. I know one time specifically, again, I went to the cardiologist and said, I got a 35-year-old that's got a patent ductus arteriosus. No, you don't. Come look at the pictures, it's a PDA, and they say, oh, yep, you're right. And let me get this straight. For every time that I've gone to a cardiologist and said that you've got this, they would say, Ray, you're stupid. That's not what it is. So for every time I did this and was right, there was 100 times that I thought I saw something and went to the cardiologist, and it was not what I thought it was, okay? I'm not saying that I was always right. I'm saying that in that particular case, I was right. And then they'd say, Ray, no, you're not right. And then I'd walk off and say, he's stupid, I know him. Okay, so we can also calculate our QPQS if we've got a patent ductus arteriosus. The problem is that this flow is not going to this outflow tract. So this is our QP up here. This is the pulmonic side, right? This is where we normally measure it if we have a left to right shunt, because it's going to go to the right ventricle, and it's going to go out the pulmonary artery here. This flow is already past the pulmonary valve, so this flow is going to go to the lungs, and it's going to go to the left atrium, and then to the left ventricle. So it's going to go out the aorta before it goes through the pulmonary valve. Does that make sense? No, not at all, right? So normally we have let's say we have an atrial septal defect, blood flow shunts to the right ventricle, goes out the pulmonary artery. So we're going to have an increased flow here, right? Our QP is going to be higher than our QS. We're going to have higher flow here than we do down here. But since this flow is already past the pulmonic valve, this flow is going this way, so it's going to go to the left atrium. It's going to go through the lungs, come back to the left atrium, go to the left ventricle. So it's going to increase flow here. So you have to reverse the formula for QPQS. Okay, does that make sense? This is going to all of our flow. Normally our shunt goes here first, but this is the only situation where a left to right shunt is going to hit the aortic valve before it hits the pulmonic valve. So the formula has to be reversed. So it's the QP is stroke volume of the LVOT. So the pulmonary flow is the flow out the LVOT, and the QS is the flow out the RVOT. Does that make sense? We just got to flip those because we measure the flow is going to a different spot. Okay, now it gets hard. Endocardial cushion defect, I already touched on this, but it's basically when everything here doesn't form. So in this case, we've got an overriding aorta, right? Because it's overriding both the atria and the ventricle, because it's not, there's nothing here. It's like someone took a shotgun and blew all this out in the middle of the heart. So you got both an overriding pulmonary artery and an overriding aortic. So endocardial cushion defect, also known as an atrioventricular canal defect, it's a combination of anomalies. It's basically a hole in the center of the heart. So the oxygenated blood mixes with the deoxygenated blood. All this blood is mixing. So instead of having an oxygen saturation of 98%, it's mixing venous blood with oxygenated blood. So you get an oxygen saturation of 80% or something like that. So you've got mixed blood. It's like you took a vial of oxygenated blood, a vial of venous blood, and mixed them all together and said, this is what's going on in the heart. You have a common valve here. So these two valves are trying to come together and close off. And it's typically associated with Down syndrome. So if you get into an echo on a Downs kid, you're going to look for an endocardial cushion defect or a septum primum defect. So you're going to really interrogate this area here to make sure that they don't have an endocardial cushion defect. Or the septum primum defect, where this did close off, but the septum didn't close off here, that's called a partial AV canal defect. It's not completely blown out, it's just the ostium primum didn't form. So that's a partial AV canal defect. So if they either have, Down syndrome and, they hear a murmur or, they're not thriving like they should, then you would want to look for any type of endocardial cushion defect or atrial septal defect, particularly a primum. And then if they have that, obviously they're going to have surgery to fix that mixing of venous blood. And echo is the tool of choice. So, we got a great shot of this heart here, especially if it's a baby. You can see this heart, you can see all this blown out. I had to go to the newborn intensive care unit on a baby that was blue, and it's a classic example. As soon as you put the transducer on the heart, you see, in babies, you usually start out with the subcostal views first because you can see all this stuff. It just, within 2 minutes, I was like, okay, this is a complete endocardial cushion defect. So it can present, they can see this if they do what do they call that, a fetal echo. So they can do a fetal echo while the baby's still in the uterus and see that all this is missing, so they can say, okay, they're going to have an endocardial cushion defect. They're probably going to be okay, in the first, several hours or weeks or days after they're born, but eventually that's going to have to be fixed. And a partial defect or a septum primum defect, we may not find it until they're 20, 30 plus years old. So they have a variety of symptoms, most associated with not getting oxygenated like they should because of the venous blood. I don't know why it looks, oh, I see, it says it looks like a butterfly because butterfly, anybody see that?
Yes.
That LSD is working for all of us, right? Oh, I'm being recorded. CMVL. Oh, cleft mitral valve. The other thing associated with an endocardial cushion defect is cleft mitral valve leaflet. So it kind of is part of that, everything in the middle not forming. So the anterior mitral valve leaflet has a hole in it, has a gap in it up here. So it's a slit-like hole. So a cleft mitral valve leaflet. Y'all know what a cleft palate is, where it's the roof of the mouth is missing. So it's kind of the same thing. It's a cleft mitral valve leaflet where it's missing up here. Slit-like hole, it divides the anterior mitral valve leaflet, most the anterior mitral valve leaflet. An isolated cleft posterior mitral valve leaflet, extremely rare. Any one I've ever seen was in the anterior leaflet. You can't have multiple clefts. 3D and 4D, so 3D echo is able to look. In our situation, we can only see the mitral valve in our two-dimensional images. But if you could take this valve and turn it and look at it like this, you could see that the mitral leaflet would have a hole in it like that. It's kind of hard to tell in a 2D. As you guys probably know, when you try to get this mitral valve in the middle of this ventricle here, Susan, when you try to get this mitral valve in here, it can be kind of difficult, right? So sometimes it'll look like there's a hole here because you're either too high or too low. So you got to be right at the tips in order to identify this. And it's almost always going to be associated with either a septum primum defect or with an endocardial cushion defect. Just to see this isolated by itself is pretty rare, and it typically requires surgical repair. They have to go in and suture this valve back together with here.
But I'll find it because I have problems with my.
Yeah, you're going to be looking at it for 15 minutes at least. So you'll probably see it. You'll think I can't get right exactly on this mitral valve because I can't get it to come together up here. And then you find out that they've got a septum primum or endocardial cushion defect. You say, oh, that's why, because it's not connected there. Echo, we're going to look at the cleft mitral valve leaflet anatomy. What's the degree of the cleft? Is it really big, or is it kind of small? Is it fibrosed? Is it thickened or scarred? And obviously they're going to have regurgitation because blood flow can go right back through that hole. And then evaluate the associated anomalies like the septum primum defect or the endocardial cushion defect. Like I said, to see this isolated just by itself, I don't even know if that's possible. Okay, pulmonic stenosis. It obstructs blood flow between the right ventricle and the pulmonary artery. So survival into adulthood is common with an unrepaired mild pulmonic stenosis. They might have a murmur, which the doctor mistakes for an innocent murmur or something that doesn't need to be evaluated. And then we find out that they've got mild pulmonic stenosis. The problem with pulmonic stenosis is it's usually not valvular. It's usually infundibular. it's not typically the valves, it's usually the outflow tract, okay? Or the infundibulum, that little corkscrew thing that you have to go to when you're going through a cave, so that infundibulum can be kinked or narrowed. So it's a stenosis of the right ventricular outflow tract. Left ventricular outflow tracts are kind of rare, except for asymmetric, except for hypertrophy, blah, blah, blah. But right ventricular outflow tract obstructions are more common than the pulmonic valve stenosis, okay? So that's another reason why we put pulse wave here, because if we have an increased velocity here, that means we've got a narrowing up here in the infundibulum or the right ventricular outflow tract. So we put pulse wave here to make sure there's no acceleration of flow before the valve. So we can put pulse wave here and we get a Doppler that looks like this. In other words, it's aliasing. We think, well, that shouldn't be aliased right there. That should be laminar flow at 1 meter per second or less. Now we've got aliasing here because it's going too fast. So that tells us that they've got an infundibular stenosis or a blockage in the outflow tract. Okay, so it's not the valve, it's in the outflow tract. Another reason why we put pulse wave here, and then why we put continuous wave here. So that's why it has subvalvular or infundibular first, because it's more common than a valvular pulmonic stenosis. Valvular pulmonic stenosis can happen, but it's usually subvalvular. So it's just the stenosis of the pulmonic valve cusps, and it's usually congenital. Acquired valvular stenosis is pretty rare. Why would you think that would be? If you're thinking about aortic stenosis being something you're going to see practically every day, aortic stenosis being very common with a buildup of calcium and fibrosis and all this stuff on the aortic valve, why would the pulmonic valve not be susceptible to that kind of deterioration that the aortic valve is?
Not as high of a pressure.
Exactly. Who said that? Yeah. The aortic valve is subjected to 125 millimeters of mercury. Every time the left ventricle squeezes, it's banging up against that aortic valve. I can do this all day. Spanking thing.
Smart to understand.
Anyway,
Don't worry, it's the least amount of HR violations.
Becky's gonna bring me in and have a talk.
Or spanking.
Please.
See?
Anyway, the aortic valve is susceptible to that 125 millimeters of mercury or 125. The pulmonic valve is like, so it's 25. Pulmonic valve's going, that's all you got. That's all you got. Come on, hit me, come on. No, I can't. I can only do 25. Sorry. So the pulmonic valve is not exposed to that spanking that the aortic valve gets. So valvular pulmonic stenosis is pretty rare. And then you can have supravalvular pulmonic stenosis, where you can have narrowing of the main pulmonary artery. So you can have, you're going to think, okay, why are you calling this supra or above the valve when it's narrowed here? Why are you calling that supravalvular? Because anatomically, this is above, because the heart comes off like this. So it's going to be down here. It's going to be above the valve anatomically, but we look at it echocardiographically. So it's supravalvular or past the valve or above the valve. Okay. Stenosis of the main pulmonary artery, and it's going to be above the pulmonic valve. So we're going to compare all of our views that we look at the pulmonic valve. We're going to look at the RV outflow tract. We're going to look at the short axis of the base. There's also another view that you can see. There's actually two other views where you can see the pulmonic valve. I'll show those to you today. So we're going to compare all the views of the pulmonic valve. We're going to use continuous wave Doppler to get the peak velocity and therefore the peak gradient. And we can do the pulmonic valve area at the exact same way that we do it for aortic stenosis. So we can take our cross-sectional area of the right ventricular outflow tract and multiply it times the VTI of the right ventricular outflow tract and divide it by the VTI of the pulmonic valve. If this was the aortic valve, it would be this exact same formula, only it would say LVOT, LVOT, and aortic valve. So it's the same formula. I don't know that I've ever done that. Because again, it's hard to give the right ventricular outflow tract accurately. It's a guess at best. You know how we do the left ventricular outflow tract? And I say, even if you don't see it that well, make it 2. It's a pretty consistent measurement, 1.8 to 2.2. So if you get 2, you're probably accurate, even though you don't really see it. That's not true of the right ventricular outflow tract. It can vary in size. So if we're guessing on that, and then we're squaring it, our error is going to be, exponentially, by definition, wrong. Does that make sense? It's because we can't really see the right ventricular outflow tract that well. So we quantify the degree of pulmonic stenosis compared to previous findings. We need to look and make sure there's no right ventricular hypertrophy. And here's how we determine how severe pulmonic stenosis is. You notice that it doesn't have pulmonic valve area up here as criteria for pulmonic stenosis, and that's because of what I just said here. It's hard to see the right ventricular outflow tract. So our criteria is if it's greater than 4, it's severe pulmonic stenosis. On our velocity, if it's 3 to 4, it's moderate. If it's less than 3, it's mild, or less than 2, it's probably normal. These numbers look familiar, exactly the same as the aortic valve. Okay, so in aortic stenosis, if the velocity is greater than 4, it's severe aortic stenosis. 3 to 4 is moderate aortic stenosis. Less than 3 is mild aortic stenosis. So this is the same as the aortic valve. And then if you think, okay, well, do I have to memorize these gradients over here? If you know these velocities, do you have to memorize these numbers over here? No, because all you got to do is take 3 times 3 is 9, 4 times 9 is 36. And then same thing here. If it's 4, just use the Bernoulli equation. 4 times 4 is 16, 64 times 4 is 64. So just use the Bernoulli equation to get those numbers. Memorize these, and then you know what the peak gradient is just by doing quick math in your head, or using a calculator, or using a machine. But if you're doing your echo and you put your continuous wave through the pulmonic valve and your velocity is greater than 4, you're thinking, okay, that's severe pulmonic stenosis. That's why we put continuous wave in the pulmonic valve. We put pulse wave in the outflow tract to see if there's infundibular stenosis. We put continuous wave through the pulmonic valve to see if there's any pulmonic stenosis. So that's why we put pulse wave and continuous wave in the pulmonic valve. That's why we put pulse wave and continuous wave in the aortic valve. There is a method to the madness that is protocol. You guys need to stretch your legs, eat some cicadas.
With barbecue sauce.
May have to carry over to tomorrow. Is she on there?
Who are you waving
I thought I was waving at Ashley. Is that her?
at? Oh, the camera.
She's second.
She's hot.
I don't know.
She's not even paying attention.
She's sleeping.
Ray asked if you were speaking.
Hey, Tricia, did you
Does your face hurt?
take that? Did you take that or did it just?
Because your face is killing me. She didn't hear the part about the spanking. I can't hear, but it can't be good. I know. We have 10 more slides.
We finish them up tonight?
What?
We finish them up tonight?
I don't know. I think it's 10 slides with a whole bunch of stuff.
And 4 of them are just like things.
Okay, good. Yeah.
Number 24.
Oh, but they're, yeah, like we're out.
Yeah, so you would take the next person coming on shift. You would take
Well, there's
the,
more numbers. See what I mean?
a couple of hours of the next shift is what I'm saying, if you're doing 10.
Correct.
Same with the lunch.
Okay, aortic coarctation. So we do this on, you guys are looking for this on every echocardiogram we do. It's a narrowing of the aorta right here. So a mild to severe narrowing of the aorta. Okay, typically in the area of the isthmus. So I think on your aorta, diagram, this area right here is considered the isthmus, because this is where the ductus arteriosus or the ligamentum arteriosus now, because this is just a ligament, it's where this attaches right in this area right here. Okay, so typically in the area of the isthmus. So if you have aortic coarctation, the left ventricle has to squeeze against this resistance right here. So anytime the left ventricle has to squeeze against resistance, that's the afterload. So it increases the afterload. So high blood pressure increases afterload. Aortic stenosis increases afterload. Aortic coarctation increases the afterload, the pressure that the left ventricle has to squeeze against. So one way you can determine the severity of an aortic coarctation is if, so let's say you have, this is the right subclavian going to the right arm, left subclavian going to the left arm. So if you take the blood pressure in the arms, the blood pressures are going to be normal, okay? The blood pressures are going to be normal. But if you take the blood pressure in the ankles or in the legs and the thigh, and yes, you can take blood pressure at the ankles. Susan and I do it. I used to do it
Yep.
every day, 3 times a day.
Yep.
So you can take blood pressures in the ankles, so that the blood pressure in the ankles is going to be lower because you don't have the pressure because of this narrowing right here. Because you have less flow to the legs than you do up here in the arms. Does that make sense? So you take the blood pressures in the arms, both arms, and it's 125 in the arms. You take it in the ankles, and it's 80 in the legs because of the decrease in pressure, because of the narrowing of the coarctation. Now, what happens is over time, and this happens in every artery in the body. If you have a narrowing like this, there's little microscopic type like connections going from here to here. So those little microscopic connections can get bigger and kind of route around this to some degree. It's not going to completely compensate for this, but it is going to get blood flow around this. Okay, it's like a detour around it that basically every artery in the body has the ability to do. Okay, so you can get collateral vessels around the blockage. If you have a coronary artery blockage, if it builds up over time, you can have collaterals going around that blockage in the coronary arteries. So if you look at a cath lab report, you'll see, 80% blockage of the right coronary artery with extensive collaterals perfusing the heart. Okay, so you can have an aortic coarctation. It can be preductal, which means up in here, or it can be juxtaductal, which means right at the level of the isthmus here, or the ductus venosus, or it can be postductal, and most of them are postductal. This is why when you do your echo, you look at the arch, you put color flow in here. If you would see turbulence here, then you put pulse wave here, pulse wave here, pulse wave here, and here your flow is going to alias because you got an acceleration of flow here that exceeds the Nyquist limit. So you would pulse wave your aliases right here, but that tells you where the narrowing is versus up here, even down here. The pulse wave tells you where the narrowing is, and then you put continuous wave through there to see how high the velocity is. So the suprasternal notch window is optimal for a coarctation, acquire the aortic coarctation diameter. So if you see this, you can take a caliper and you can put it here, and then you put a caliper here, and then you can calculate, the difference between here and here. You can calculate how narrow it is. Utilize color flow Doppler to detect any turbulence. Utilize continuous wave Doppler to acquire the peak velocity and the peak gradient. And with this pulse wave, you're just gonna track it down and see where does the flow alias, where does the flow accelerate, and where's the turbulence, and that tells you where the where the narrowing is. It's important if they're going to go in and repair this for the surgeon to know, okay, he's got to deal with, maybe he's got to deal with this subclavian artery. He's got to detach this, fix it here, and then reattach the subclavian. Or maybe here, he's got to deal with this ligament right here, down here, it's free lunch. Okay, so, and then evaluate any associated anomalies. What other associated heart condition would we expect, or could we see with a coarctation? Anybody? Going to be disappointed if somebody doesn't come up with it.
Bicuspid valve.
1,000 points. By the way, you get 1,000 points per year. Freshman too. So bicuspid aortic valve. With a bicuspid aortic valve, think aortic coarctation. Coarctation, think of bicuspid aortic valve. For some reason, they go together. Epstein's anomaly. Put it up here for you. That's another one you're going to need to know. That's when your tricuspid valve is displaced towards apex. So typically, when we do our 4-chamber view, we know that the tricuspid valve is going to be slightly closer to the apex than the mitral valve. That's one of the two things that tells us that this is the right ventricle. There's a moderator band up here, and our tricuspid valve is just like two millimeters higher than the mitral valve. So that tells us that this is indeed the right heart because of those two things. With Epstein's anomaly, we have the tricuspid valve is displaced all the way up towards the apex. So the tricuspid valve could even be way up here. So what does that do? It makes this atrium, they don't communicate, but the right atrium is really, really big. And the right ventricle is really, really small. So basically you have a huge right atrium and a little teeny right ventricle because the tricuspid valve's all the way up here, all the way up here. So this is called an atrialized right ventricle. What should be the right ventricle all the way down to here is now turned into atrium in this area right here. So you have a little teeny right ventricle that's now responsible for supplying the lungs with blood. So the right ventricle, portion of the right ventricle becomes atrialized and serves as part of the right atrium. So Epstein's anomaly is just when the right ventricle, the tricuspid valve, is more apically displaced than we would expect to see. Okay. We're going to utilize and compare all views. We're going to look at our RV inflow view. We're going to look at our peristernal short axis view, the tricuspid valve. We're going to look at our subcostal view, 4-chamber view. We're going to look at all of our views to just verify that that tricuspid valve is towards the apex. And sometimes it can be, like, what if it's like right here? You're thinking, okay, is that Epstein's or is that just normal? So sometimes if it gets down in here, it's really hard to tell. You might not think that's Epstein's, but the cardiologist might disagree with you and say, I think that's Epstein's anomaly. Okay. So we're going to have a large right atrium, PFOs or secundum ASDs. I want you guys to get comfortable with this being a secundum ASD and this being a primum ASD. If you have even a little nubbin here, just a little nubbin right here, that means that this formed, so it's a secundum ASD. Any little thumbnail hanging down here is going to discount it as a primum ASD. If it's up here, it's a secundum ASD. But their secundums are usually right here in the middle. So I want you to get familiar with that. So you can have a PFO or a secundum ASD. You're going to have a small right ventricle. The tricuspid valve leaflet's going to be displaced. Likely, if these are way up in the apex, you're going to have tricuspid regurgitation. You're going to have right heart failure, and then again have associated anomalies. I know you don't know what this means, but Wolff Parkinson White is a rapid heart rate. That's associated with Epstein's anomaly. So basically, you're just going to document that the tricuspid valve is way lower in apex than it should be. Tetralogy of Fallot. Okay, this is the most common cyanotic lesion in babies, which then babies, if I'm not mistaken, turn into adults, and then, you know, well, first they go from babies to little shitheads called teenagers, and then they turn into adults, which turn into a, you know, pain in the ass for parents. Sorry about the colorful language, but you know, my cynicism is again. So, and then they have grandkids, and it makes up for all of it. You know, it's like, okay, you were horrible as a teenager. Now you're an adult that, you know, constantly needs money or constantly getting into trouble or whatever. But now you have grandkids, all is forgiven. Thank you. So tetralogy of Fallot, 4 defects. Tet means 4. So tet, 4 defects, and you really only have to know 2 of these, and then the others you can deduce. Okay, so you've got a malaligned atrium, or aorta, I'm sorry. So the aorta is overriding both the left ventricle and the right ventricle. So you've got an overriding aorta. So if you've got an overriding aorta like this, what do you have? Anybody? A VSD. Yeah, you've got a ventricular septal defect. So if you've got an overriding aorta, then by definition, you've got a VSD here. You've got shunting going on between the left ventricle and the right ventricle. So if you can remember that a tetralogy of Fallot has an overriding aorta, which is like the predominant feature, then just by definition, they're going to have a ventricular septal defect. So that's 2, right? So then they're going to have pulmonic stenosis, probably infundibular stenosis, possibly valvular stenosis. So if they've got pulmonic stenosis, subsequently they're going to have right ventricular hypertrophy. This right ventricle is going to be really thick because it's trying to squeeze against the restriction in the pulmonary artery. So 4 defects: overriding aorta, which by definition gives you a VSD. You've got pulmonic stenosis, and because of the pulmonic stenosis, they've got right ventricular hypertrophy. So if you can remember this one and this one, you can deduce this one and this one. So if the test says, you know, what are the four anomalies or the 4 defects associated with tetralogy of Fallot, then if you can remember a malaligned aorta, which gives you a VSD, and this pulmonic stenosis is almost always going to be infundibular, because if you've got an aorta that's now impinging on this space over here, this aorta is sort of impinging on the pulmonary artery and kind of compressing it. So it's usually an infundibular pulmonic stenosis, or it could be both. It could be an infundibular and a valvular pulmonic stenosis. But just like an aortic stenosis gives you left ventricular hypertrophy due to the increase in afterload, same thing in the right ventricle. The right ventricle is going to hypertrophy because of the decrease in right ventricular afterload from either the infundibular or the pulmonic stenosis. So those are the 4 things with tetralogy of Fallot.
So why is it stenosis? The common cyanotic lesion? Why is that?
Because it's since the blood is mixing here, it causes the baby to be cyanotic. They're not getting 98% saturation; they're getting 80% or 78%, or, you know. So their lips are blue, they're cyanotic, every baby that's born with this, because of all this mixing of blood in here. And the life expectancy for this, before they had heart surgery, was essentially 5 or 6 years old. Now they can surgically repair this thanks to a surgical procedure that was invented back in the probably 40s, 1940s maybe. It was groundbreaking. Before this, before they decided that something had to be done with this, we can't let these babies die. We got to do something. Before this, the heart surgically was off limits. It was, it was unheard of. Nobody was going to operate on the heart itself. It couldn't be done. Nobody could survive it. And so they developed a surgical technique, and it was very, very controversial when someone or someones went out on a limb and tried to do this. And now babies that are born with tetralogy of Fallot, they have this surgical repair and they live a full life. Now, when you do an echocardiogram, and it's going to be for a TET repair, it's going to look identical to a normal echo. The only thing you're going to see, so you do your parasternal long axis, the only thing you might see is that the aorta comes off like this. I'm trying to draw the root in here. So the aorta comes off like this. What they did was they just put a patch here. So instead of this overriding aorta, they put a patch in here of Teflon or brick and mortar, whatever, to close this off. And then the pulmonary artery that's narrowed here, going through the pulmonic valve, they just go in and they surgically, cut this part out and this part out and just enlarge it. They make this bigger. So they fixed the two things that are causing the problem. They fixed the overriding aorta, so now they don't have a VSD anymore. They fixed the pulmonic stenosis, so now their right ventricle goes down to a normal thickness. Okay, if you bulk up your biceps, it's going to be thicker. But if you quit doing that over the course of a year, 2 years, you're going to get wimpy like me again. So if you fix this, put a patch here and fix this overriding aorta, then and then fix this, then you do an echocardiogram, it's going to look like a normal echocardiogram. You're going to even know the difference. You're going to look very closely at this area right here to try to see the patch, and you're going to put color flow on here just to make sure that there's not a leak around the patch. But other than that, you're basically doing a normal echo. And of course, you're measuring your outflow. You're putting your pulse wave here to make sure that what they fixed up here is not getting worse or not re-narrowing. So those are the things you do with tetralogy of Fallot. Back when they first started doing the surgery, all they did was, so they couldn't get blood flow to the lungs because of this. So they just took so this is the subclavian artery, and going to the right arm, they just connected a shunt going to the pulmonary artery here, so it bypassed this. So we had a shunt going from the pulmonary artery to the subclavian, so it bypassed this blockage that was down here. And that was called a BT shunt. And that's what saved these babies' lives. And it should be called, and is now called, this is the two doctors that did this. It should be called a BTT T shunt. Because this person played a tremendous role in developing this technique, but got no credit for it.
Is she female?
But
Is she female?
coincidentally, this was a male, this was a female, and I'll let you guys watch the movie tomorrow.
Is that Snake?
Huh?
Is that Snake?
Snake?
Yeah.
Oh, Deaf Mo, Mo Deaf.
No. The famous British actor was in it.
Oh, no, he's this.
Oh, okay.
Yeah, what's his name again?
Well, he's Snape in Harry Potter.
Oh, okay.
Nobody else watch Harry Potter?
I don't know.
Long time ago, Will.
Okay, she gave it.
No, the actor. No, he was an actor.
Snape.
Who's the character?
Yeah.
He was also in Die Hard.
Hard. That's playing
Was it really?
the bee.
I've never seen that
movie
one.
too. The bee doctor.
Wait,
I mean, it was a
No,
reach
actually,
from Will.
you're not
to really
actually.
go follow the, no, investigation.
You've never seen
Yeah.
Die Hard movie first? Yippee-ki-yay.
I mean, I get the cultural reference.
Okay. Okay, so
Put it all
Tetra,
together, man.
I guess we need to watch Die Hard.
Yeah.
Jeez. He just died not too long ago, by the way.
Who?
Your
Yeah.
Harry Potter. So transposition of the great arteries. There's two types of transposition. Okay. Transposition of the great arteries. Can you imagine this situation? So there's two types. You've got DTGA, or you've got dextro, and all dextro means is right. Okay, it's R-I-G-H-T. Okay, that's all that means. So it has nothing to do, a dextro transposition has nothing to do with the heart being over here. It has nothing to do with that. Okay? When the heart develops, the heart has to go to the right. That has nothing to do with either one of these transposition things. So we get dextro transposition, which is D, transposition of the great arteries, DTGA, or we get LTGA. Okay? You know how you can memorize the difference?
L was left.
No.
D was
This.
right.
D stands for you can live with this. You can't live with this.
It's a little more dramatic.
It's a little more dramatic, but you know, it's an easy way to remember. Because if you got a patient with D transposition, as soon as they're born, it's a race for survival. From the second that they're born, it's a race to get them to survive. Okay.
Darth and Luke.
What?
Be Darth and Luke.
There you go. Whatever works. Yeah.
Just trying to follow
Yes.
Will's examples.
Darth Vader, the bad guy, worst. Luke, the good guy. Wow. I'm gonna remember that. Maybe. Not long. So detransposition. So what happens is basically the arteries do just what we say. They transpose. So you've got the left ventricle and the left atrium and the right ventricle and the right atrium, and coming off here, you have the aorta normally going to the body, And here you have the pulmonary artery going to the lungs, right? So this goes out the aorta, it goes to the body, it comes back to the right atrium, it goes to the lungs, it comes back to the pulmonary veins. So it's circulating between the two chambers, right? So what happens is you put the aorta over here, put that there. You put the aorta over here, and you put the pulmonary artery over here. So now this gets pumped to the body, and then it comes, it gets pumped. It's going out the pulmonary artery, it goes to the lungs. I'm getting better at drawing the lungs. It goes to the lungs, and then it comes back through the pulmonary veins, comes into the left atrium, goes out the pulmonary artery, goes to the lungs, comes back to the left atrium, goes to the left ventricle, goes out the pulmonary artery. You see the problem there? So this is now the aorta, which goes to the body. So blood flow comes back from the superior vena cava, inferior vena cava. It's venous blood. It goes to the left ventricle. It goes out the aorta. It goes to the body. It comes back to the superior vena cava. Goes here. Goes to the body. So you got two completely separate. There's no communication between. So you got oxygenated blood, plenty of it, plenty of oxygenated blood on this side of the heart, and deoxygenated blood on this side of the heart, and they don't communicate at all. Okay, you see how that could be deadly? So the only thing that can cause a baby to survive this type of situation is to have a shunt here. So first thing they do is even in a newborn baby, they go in with a catheter and they just blow this open. They blow open the foraminophalanx. They blow a big hole in here so that blood flow, this oxygenated blood flow, can come over here and mix over here, and then the venous blood can come over here and mix over here. So you got to have this mixing right here, and hopefully you're going to have the patent ductus arteriosus, which connects the pulmonary artery to the aorta. We need to keep that open as well. We need to keep as many, and hopefully, cross your fingers that they've got a VST as well, so that you can get the mixed blood over here, and this blood over here, and this blood here over here, and this blood here, over to there. So somehow we got to get oxygenated blood over to here and deoxygenated blood over here to mix the two. If you don't, there's no hope.
So that's their life, right? From that point on.
No. Now, so they're born with this. They can't live more than a few hours at most if they're lucky. So now, what they do is they just whack this off and attach this over here and whack this off and put it over here. So now the aorta is going to the body again, and the pulmonary arteries now, they just switch the arteries. It didn't used to be that simple. It used to be that they would have to create a baffle between the atria here, or they would take basically a connection to go from here to here, and a connection that would go from here over to here. So the blood flow coming back, deoxygenated blood coming back to the right ventricle would be routed over to here, so it could go over to this ventricle to get pumped to the lungs, and then oxygenated blood would be channeled over to the right atrium for the right ventricle to pump it to the body. Okay, so this is called a muster procedure. Okay, so you'll probably, you know, if you're working in a place that does adult congenitals, or even if you're not, you could have somebody walk in the door and say, I had heart surgery when I was born, and you see the pulmonary artery coming off, and you see it bifurcate what's supposed to be the aorta, so you know that's the pulmonary artery. And then you see all this stuff in the atrium, this baffling system going on here. This is what they used to have to do because they didn't have the ability to do microsurgery to disconnect, you know, the coronary arteries. Now the surgeons wear those goggles that are magnifying everything so they can see what they're doing, and they can do little surgical procedures. So now they can just do an atrial switch. They just switch the aorta to the pulmonary artery, and it's easy and done. Used to be like this. These are a nightmare to try to do echo on. So if the anterior chamber is the right ventricle, the posterior chamber is the left ventricle. So the right ventricle is pumping out the aorta, the pulmonary artery is pumping pumping to the body. So you got systemic flow that goes. So systemic flow goes to the right atrium, to the right ventricle, out the aorta into the body, and back to the right atrium again. Pulmonary venous flow goes from the left atrium to the left ventricle, to the pulmonary arteries, back to the lungs again. So these two are different, okay? They don't communicate. So what we have to do is we have to have a PFO here, or an atrial septal defect, and hopefully we have a ventricular septal defect, and hopefully we have a patent ductus arteriosus, so we can mix this blood inside the heart, so that when it goes to the body, it's mixed blood. So we got two totally independent parallel circuits. It's crucial that the two circuits get communicated by a PFO, a PDA, or hopefully even a VSD. If these shunts close, because this PDA, what is it? What did we say? It closed within 7 hours or something like that. If this closes and this patent foramen valley closes and there's no VSD, it's sudden death. There's no way they can survive without getting oxygen to the brain or the body. If it's going back to the lungs, back to the right heart, back to the lungs, and then you get it. They can give prostaglandin. I think this is one of your test questions. They give prostaglandin. It's a chemical that keeps this PDA open. So the first thing they do is they give prostaglandin to the baby, and then they go in with a catheter and they blow open this atrial septum here so they get mixed venous blood.
Is prostaglandin a puts you to sleep?
Prostaglandin is just a medication that makes vessels stay open. Okay. Specifically, this patent ductus arteriosus, it keeps it from closing down into a ligament. It keeps it open, so they have to give it prostaglandin.
Can you repeat that? What is it?
Prostaglandin, Prostaglandin. I think it's a hormone that keeps that from shutting down. Yeah. Which one? What'd you say?
I thought I want to see it.
It's in 295 in the book.
I'll remind me. I'll look up which question it is. They can be intensely cyanotic. They can be as blue as a Smurf because they're not getting any oxygen to the body. Okay? And then you got to evaluate for any associated anomalies. With all congenital defects, you got to make sure that there's no other communicating, no other associated problems with the heart. If it's this screwed up, something else could possibly be screwed up. But I don't know anything that could be more screwed up than this. So that's D. You can see how the D can be the Darth Vader in this situation, or death in this situation, if it's not fixed within the first few hours of life. And then you have L transposition, sometimes called corrected transposition. And all this is it's just a switching of the chambers. The D transposition has to do with, when we were talking about embryology, we had the truncus arteriosus, so off the heart we just had one vessel, and then this vessel kind of pinched together like this, and then it's separated into two. So if this separates into the pulmonary artery in the aorta here, if they pinch off incorrectly, that's when you get D transposition. In L transposition, the ventricles just transpose. So you've got the right ventricle here. How do you know that's the right ventricle? Two ways. And tricuspid valve more towards the apex. And so this is the right ventricle. It pumps out the aorta like this. So your 5-chamber view is going to look like a 5-chamber view with the blood flow going to the aorta. And what's the left ventricle is going to pump out the so this is the aorta. This is going to pump out the pulmonary artery to go to the lungs. So everything's working right. This chamber is pumping out the aorta, and then all this blood's going to the body, coming back from the vena cava into here, going to the left ventricle. The morphologic left ventricle is pumping out the pulmonary artery, going to the lungs, and then coming back into. So everything is correct except for the right ventricle is over here and the left ventricle is over here. So the ventricles are just transposed, and you can live with this. The only problem with this is the right ventricle is a thin-walled chamber. The left ventricle is very thick. So the right ventricle is not used to squeezing against, if it's going out the aorta to the body, it's going to be 125 millimeters of mercury. So the right ventricle is not used to that. It's not built for that. The left ventricle is muscular. It's built for pumping against 125 millimeters of mercury. But instead, now the right ventricle has to do that. And now the left ventricle is over here with, sunglasses and sitting in a beach chair and drinking, Mai Tais or whatever you drink at the beach. And again, it's a piece of cake. I've got a big, thick muscle here. I only have to pump against 25 millimeters of mercury. I'm on vacation forever. The right ventricle is going, why did I get put on this chain thing of having to do this?
Over time, will that right ventricle beef up?
No, it'll fail.
Oh, really?
It doesn't really beef up. It gets bigger, and eventually you get right heart failure and then systemic congestion and all that associated stuff with that. I did a lady in a nursing home. She was on oxygen, and again, I could see the moderator band up here. I could see that the aorta was coming off because I looked at this and I could see that this was branching, that this was the pulmonary artery, that this was definitely the right ventricle because of the moderator band and the tricuspid valve. Now, I went out, had to go out of the office and go to this nursing home to do this echo. Now, the lady she was short of breath, she was on oxygen, all this stuff. She was like in her 80s. And I came back, I told the cardiologist, I said, I just did an 80-year-old lady that's got, L transposition. He said, that's not possible. I said, what did I say? Look at the echo. And they said, oh my gosh, you got an 80-year-old with transposition. Again. But then again, for every time I did that, there were 100 times when I did that, and then they were like, stay in your lane. But it's good. That's one of the beauties of being an echo tech, right? Because you get to see this stuff and you get to make this so-called diagnosis and then come back and tell a cardiologist what you see, and they say, that's not possible, you're crazy. And then they look at the echo and they say, oh, you're right.
Crazy like a fox. Crazy like a fox.
Crazy like a, yeah. Like you've been doing it for a day or two. So L transposition, you can live with it. The ventricles are just transposed. So you got the right ventricle, so you got the left ventricle pumping out to the pulmonary artery, and you get the right ventricle pumping to the body. But everything else comes back the way it's supposed to. So you got oxygenated blood coming back to the left atrium, and you got deoxygenated blood from the vena cava coming back into the right atrium, which is you got the left ventricle trying to do the work that the right ventricle is supposed to be doing. Okay, so the ventricles are just transposed. Okay. And by the way, the valves always follow the chambers. So if this right ventricle comes over here, the tricuspid valve is going to go with it. If the left ventricle goes over here, the mitral valve is going to go with it. So this is going to go from the right atrium through the mitral valve into the left ventricle. This is going to go from the left atrium through the tricuspid valve to the right ventricle, because the valves always go with the ventricles. So you have to be able to identify this diagram. What's A is normal, B is detransposition, and C is, since these are transposed here, is L transposition. Hypoplastic left heart syndrome. This is the last one, I think. Yes. Hypoplastic left heart syndrome. This is where the baby essentially has no left ventricle. They have a single chamber. You know, I've talked about doing echocardiograms where all you see is one chamber. This is one of those cases that causes that. The left ventricle does not develop. So it's uncommon, it's complex, it's underdevelopment of the left heart, because either the mitral valve didn't form, and so no blood flow can go to the left ventricle. So if in fetal development, if the left ventricle has no blood, there's no reason for it to even exist. So it kind of fades away. Okay, so you see a heart that looks like this. If you're looking at it from an echo standpoint, you're looking at a ventricle like this, and then over here you might see, you know, a little bit of left ventricle here. Okay, so you basically got one chamber pumping out the pulmonary artery and pumping out the aorta. So a single chamber, because the left ventricle didn't form because there was no mitral valve here. You got a little teeny mitral valve. So no blood flow went into the left ventricle. Anyway, no blood flow through the mitral valve to the left ventricle, so the right ventricle does all the work, does all the development. So you got a right ventricle that's squeezing out both the pulmonary artery and the aorta. So hypoplastic left heart syndrome, mitral valve atresia. Atresia just means that it didn't develop, or it developed into something that doesn't even remotely resemble a mitral valve. Or aortic valve atresia. Again, if the left ventricle has nothing to pump out into, the left ventricle is like, why am I here? So it just doesn't develop. Or aortic hypoplasia, where the aorta doesn't develop, so there's nothing to pump into.
Hypoplasia was what? Definition of hypoplasia?
Hypoplasia means underdevelopment.
Oh, I thought that was atresia.
Atresia is where it essentially doesn't develop.
Oh,
Hypo-
underdevelopment.
Underdeveloped.
Okay, sorry.
Atresia, A means without.
Okay.
So
Got it.
without development. Essentially, you have no mitral valve.
Got it.
Nothing for the blood flow to go into the left ventricle. So the criteria for diagnosis You're gonna measure the aortic valvular annular size. You're gonna measure, the left ventricle is gonna be less than 1 centimeter. What do we like to see the left ventricle? Or, yeah, the wall, posterior wall is 1, but, so imagine a left ventricle that's less than the width of the posterior wall. That's a non-existent left ventricle, right? If it's 1 centimeter big, that's not a left ventricle, that's a dream.
That sounds like death.
Huh?
Sounds like death.
Yeah, it does. The mitral valve is distorted or absent. In utero, the ductus arteriosus and the foraminal valley assist in proper circulation. At birth, I had the perfect example of this. The perfect example. I may have told you guys the story. If I did, stop. I was on call, and it was a Sunday, and I got a call from the emergency room. They said, we got a baby that needs to have an echocardiogram. The parents say the baby got blue, got really, really dark blue at home, and now it's having trouble breathing. So I go in there, and the baby, doesn't look that blue to me, and it seems to be okay. So I'm yucking it up with the parent. Have I told you this story? I'm yucking it up with the parents. It's a Sunday. Everything's slow in the ER. I'm kind of joking around and playing with the baby a little bit. And they said that they had just gone home the day before. They went home on Saturday, and then during the night or early that morning, the baby turned blue, and so they brought it to the emergency room and looked relatively okay. And so I do the, like I said, I'm yucking it up with the parents, and I put the transducer down, and I see that there's no left ventricle, and I'm like, holy crap. So now I'm not yucking it up anymore. I'm focused and concentrating, trying to get the best pictures and all this stuff. So here comes the doctor. He comes in, he's drinking coffee, and he said, everything's okay, right? Everything's just fine. He said, we just discharged this baby yesterday, so, I'm sure everything's okay. I said, we need to talk. I said, the baby's got a hypoplastic left heart syndrome. He goes, what do we do for that? I said, you got to get the baby to St. Louis. I was working in Columbia, Missouri at the time. I said, the baby needs to get to St. Louis ASAP. So what happened is the baby was born, and the ductus arteriosus was open, and the PFO was open. So there was mixing of blood, so the baby looked fine. And then during the night, the baby's PDA closed off and the PFO closed off. So now there was the left ventricle couldn't pump. So the left heart's too small, unable to pump blood to the body, and then they get suddenly get a lot worse, life-threateningly worse. Okay, so they have a volume pressure overload, so blood shunts from right to left, if it can shunt at all, because they've closed off. So the treatment with advanced technology and today's surgical procedures in early detection and the immediate transfer to a highly skilled pediatric surgeon, they can surgically do the best they can to try to reroute blood. At birth they're going to get prostaglandin, and then once they're stable, they can go in and do surgery. But still, the baby's only going to have one ventricle, right? So they have to bypass circuits and conduits and all this stuff to fix this problem. And maybe they'll live to middle age or something like that. I don't know. They can now diagnose hypoplastic left heart syndrome with a fetal echo. That's why fetal echo is exploding, because if we can go in and look at the heart and see these things before the baby's even born,
then you're prepared.
Then you're prepared. You can have the mom sent to in this case, St. Louis Children's Hospital, the mom would deliver the baby there, and they would immediately start doing whatever they had to do to save the baby. So, the fetal echocardiograms are, or if they've got transposition, they can see that, so they can, as soon as the baby's born, they can plan to, what they need to do. They know they gotta go, they get everything ready, they need to go in and blow open the atrial septum. So hypoplastic left heart syndrome is a pretty devastating diagnosis as well. And it's-
I've always done the right outflow and the left outflow on babies, but just simple shots.
Yeah,
This is much more. So is it later in pregnancy to get fetal echo or when?
I think they can see this stuff pretty early, but the machines are specifically designed to look at, little baby hearts. Not baby hearts, but fetal hearts, and make sure
super
all the
high
connections.
Frequency transducer.
Yeah, and the technicians know how to move the transducer to get the best views for, all of these connections.
So they're not doing the biophysical, they're just doing.
They're just doing the heart.
Okay.
That's all they do. Yeah, they're not looking at the other stuff. They're not doing femur length or cranial area or any of that stuff. They're just looking at the heart because that's their expertise, specifically to look for fetal hearts. Okay, that's a lot.
Mm-hmm.
Okay, which question did you have?
Prostate landing.
$45. $46. What do I have? How do I have it worded? That would be L transfusion. The other one, you need to know not the specific anatomy, but know you have two separate circuits, and then what do you do to keep those circuits open? And the network is coming in there. All right.
24. But just the eventual switch systemic is the left heart and the heart is the right heart.
What did I say?
What happens to eventual L dash transposition, which is systemic and which is not. So the left heart, the systemic is the
Okay, lunch. Did Maylin come in with you, Ally?
No, she'll be with me tomorrow though.
Oh, okay. So you want to, Hadley want to stand here?